Record on this. Hi, everyone. Welcome to Nutritional Support for the Patient on Medication. We'll be videotaping this, and I would like to welcome my guests, Dr. Jillian Campbell and Dr. Matthew Fraczek-Syczyk, both who, like me, have a master's in applied clinical nutrition. Let them introduce a short little thing about themselves. Dr. Jillian.
Hi, I'm Dr. Campbell. Yes, I took many courses from Dr. Balliet and have learned many things even since graduating. And I really like the drug-induced nutrient depletion because I feel like it's an easy thing that can have a significant impact on patients' health.
Dr. Matt.
Yeah, and same here. I took plenty of courses with Dr. Balliet, and I loved taking the master's in nutrition as well. I learned a lot of really good information, and I always love the drug-induced nutrient depletion talks too. And I dive a little bit into it in my nutrition consults with patients as well. So very exciting stuff.
Great. So we're gonna go. I'm gonna share the screen, and we're gonna do the PowerPoint. And so I really want to thank. Let's get this up and running. I really want to thank Dr. Jillian and Dr. Matt because truthfully, they did a phenomenal job helping me on this. So I'm going to try to do this so that only small active, right? Whoever's speaking is going to show, hopefully that's who's going to be on this. And so this is nutritional support for the general health of the patient on medication that is in all of our scopes. So all we have to do is ask people what meds they're on. And even in New York, we can recommend supplementation that helps mitigate that. And so let's get this rolling here. Hopefully, there we go. And so, Dr. Jillian.
Okay, so we're all here because most Americans are on at least one prescription medication. As we get older, the amount of prescriptions that we get tends to increase, and the overall rate of polypharmacy is still on the rise. And while it's not in our scope to tell people what medications they should or should not be taking, like Dr. B said, it's definitely in our scope to educate them about these medications, about how they may be impacting their nutrition and overall health. And so why do we think it's important to talk to people about their medications and educate them? Well, a lot of my patients come in and they don't even know why they're taking the medication that they're taking. They just know that they're taking it. And according to the World Health Organization, almost 50% of people may be taking their medications incorrectly. So that indicates to me that the patient education piece is not there. They're not receiving the education about their medications and their health in a way that they can understand and digest and take on board and do correctly at home. Additionally, many patients have no idea that a majority of side effects are due to nutrient depletions that are caused by the drug's mechanism of action.
So what we really want to talk about here is that the mechanism of the drug-induced nutrient depletion is one of three main ways. And that is some medications compete for nutrients when detoxified in the liver. So that's this one here. We're really looking at a liver problem. And therefore, I'm going to suck out all of the vitamins and minerals that I need for other pathways. And that's what's going to cause the issue. And then some medications interfere with specific biochemical pathways. And we're going to talk about that, especially for CoQ10. And then some medications actually interfere with digestion. And so now I either can't digest them or I can't absorb them or both. So basically, we're going to start with this, the cytochrome P450 system. And I'm just trying to get this to work right. Anyway, here we go. And I'm going to go back to that for a second. So what's really interesting about this is this idea of competing for nutrients. 75% of all medication, prescription or non-prescription drugs, have to go through the cytochrome P450 system to be quote unquote detoxified. When I look at the cytochrome P450 system that was discovered by Dr. Ron Estabrook, it was named cytochrome P450 because it absorbed light at this wavelength of 450 And what actually happens is this. In the first phase of liver detoxification that we see here on this picture of the liver, is step one is actually oxidation. That means I am burning whatever is not food. And as we know, and I say to my patients, picture a field of tires on fire. A tires in the field, that's bad, but tires on fire is much worse. So what happens is when I start to burn everything, I'm going to use up the B vitamins, 1, 2, 3, energy, all the things for the Krebs cycle. I'm going to really have an impact on folic acid. I'm going to need a lot more antioxidants. Things like milk thistle is going to upregulate actually the phase 1, more burning. And I'm going to need then antioxidants to put the fire out, like the carotenoids, like vitamin E, like vitamin C. And the second step, which is all I'm going to now have to put the fire out, that needs me to basically add sulfur or use L-glutamine or use taurine, which is a derivative of cysteine, a sulfur-containing amino acid. I need glycine to make bile. And I'm going to need cruciferous vegetables just in general, because I'm going to need those antioxidants. What is considered a toxin that you put in your body? That is anything, believe it or not, that's not food. So you had food that's not organic and it has pesticides in it. It has insecticides. It has a dye. It has a food color. And then again, any drug, over-the-counter prescription, and alcohol. When I take the second step where I'm going to do something to detoxify it, the water-soluble ones are going to go in through the kidney and out into the urine, and the fat-soluble ones are going to have to be put out in the bile and then go out. And that really, this section here, when it's going out through the bile, is so important to have fiber so that I can really move it out. So again, this is super important, 75% of everything going through the system. I wanted to bring up, as we were talking about this with Dr. Campbell and Dr. Fraczek-Syczyk, what we were saying is we really want to talk about anything that interferes or interacts with the cytochrome P450 system. There are two things that have a lot of impact on the system, and that is grapefruit and grapefruit juice, and then that picture is St. John's wort. These have the most negative impact with the largest number of drug interactions. So we really want to recommend to patients who are on any kind of medicine that they really have to check. It really may not be a good idea for them to do grapefruit or grapefruit juice. And a lot of drugs, they should not do St. John's wort. It will so upregulate the cytochrome P450 system, they won't get the positive benefit of the drug. So I would say these are two things that most people that are on medication should try to avoid in general. What's intriguing is that hormone replacement therapy for women, whether I'm using contraceptive as birth control pills or any kind of other hormonal birth control, and I have a list of that at the end, the rings, the shot, the implants, those are known to deplete B6, magnesium, and all the B vitamins. And when we look at what the effects of the loss of those nutrients are on the right-hand side, when I cannot have enough B6, I'm not going to be able to get rid of my water. So I'm going to get edema. That's going to up my cardiovascular risk. If I don't have enough magnesium, I'm going to have a lot of problems with my mood, with my cardiovascular health. When I cannot have my B vitamins, I'm going to be exhausted. And when I don't have the right folic acid, B12, I'm going to have elevated homocysteine levels that can cause neurological diseases. So all of these things are really impacted by both birth control pills and, intriguingly, hormone replacement therapy. Hormone replacement therapy does not deplete the B vitamins to quite the same level as birth control pills, but definitely has an impact. And so a lot of postmenopausal women on that, they still really should have their B vitamins as well. It's just that B6 and magnesium are going to be severely depleted in that. What I find really interesting when they're giving pain medication, acetaminophen or Tylenol is in the majority of pain medication. Even if you are having something like Robitussin, it may have acetaminophen in it. It's in so many things. It actually depletes glutathione, and glutathione is one of the most important antioxidants in the liver and in red blood cells. When I do not have glutathione, I cannot do phase 2 liver detox. That means I cannot put the fire out. And acetaminophen is known to be a liver toxin. It's known to be a red blood cell toxin. And what I find intriguing is they'll say that acetaminophen is safe for kids, but I really think it's a huge problematic drug. Unfortunately, glutathione is very hard to replete because unless you use liposomal glutathione, it's going to be digested to the 3 amino acids that it makes it up, and now you're going to have to remake it. It's not really that easy to replete. And so while you cannot tell people to stop that, you might want to have them go to the pharmacist, let them know that has impact on their liver, and see if the pharmacist cannot support them in another choice. That's kind of the way that I handle that. A lot of patients that we all are seeing are on NSAIDs like ibuprofen, naproxen, Advil, naproxen. Intriguingly, they deplete melatonin. And so I need melatonin to have a good night's sleep. And so we'll have a slide later about melatonin. Folic acid, very important for wound healing because it's in that cycle of DNA synthesis. So again, I'm going to have a lot of problems. And intriguingly, it can lead to iron deficiency because while NSAIDs are not as problematic as salicylates in depleting iron, it can cause a low-grade bleed, which can then lead to anemia. And then once I have that, then I can have the hair loss, the weakness, the brittle nails, all of that. So we just want to replete those things. But again, the iron in the folic acid is only going to be depleted to about the RDA. And melatonin, we're going to talk about dosage for about 1 to 3 milligrams of melatonin. The salicylates, which are aspirin, that problem with them is really the iron and vitamin C deficiency. Very likely with salicylates, I'm going to have a low-grade bleed. The reason is that the mechanism of action of aspirin is a non-competitive inhibitor of the COX enzyme, and it particularly shuts off platelets. So I have a lot of trouble clotting. And because it impacts the platelets, I can really negatively impact sodium and potassium because of the whole way that red blood cells really rely on the sodium potassium ATPase pump. So the iron and the vitamin C, pay a lot of attention to that. And then again, the folic acid that we saw with the NSAIDs. And so we want to make sure that we have some folic acid for them to replete the salicylates. Jillian.
And the second mechanism of action is the drugs that interfere with a biochemical pathway. So statins are a really good example of this. They're actually a competitive inhibitor of HMG-CoA reductase. So you can see at the top of the reaction where the statin drug has its effect and therefore blocks the reaction from moving forward. So you eliminate all of these downstream compounds. So not only does it inhibit our ability to make cholesterol, which is why the patients are taking a statin, but it also inhibits our ability to make ubiquinone, which is CoQ10. So a lot of cardiovascular drugs work via this mechanism. And you can see statins, beta blockers, metformin, they all deplete CoQ10. These effects are going to be some of the things you may see as symptoms in your patients, like fatigue, loss of energy, might have some brain fog, and some people might have muscle pain, aches, cramping, things like that. ACE inhibitors are going to deplete zinc. So those are the people that probably get sick more often than others, or they stay sick for a lot longer. They might have slow wound healing, and they may also present with indigestion because of the decreased ability to make stomach acid that's sufficient to digest their food. Diuretics, there's a whole huge list here. You can see that they deplete. Some of these patients are going to have similar symptoms as the other or nutrient depletions, a lot of fatigue, a lot of kind of brain fog, maybe memory issues. Their cardiovascular health may not be that great, but they're on cardiovascular drugs, so you already expected that. Some people that maybe are presenting with osteoporosis or osteopenia that's getting worse, you can always check their medications, see what they're on, and then see if maybe there's something nutritional you can do to support those symptoms and impact their overall health in a positive way. Another thing that's really important to keep in mind with statins is there is such thing as statin-induced myopathy. So we do see a lot of patients in our office that come in with muscle aches and pains, and we just want to make sure it's not an effect of a medication that they're taking. Three main ways that this comes about with statins: because of the statins mechanism of action, inhibiting that HMG-CoA reductase causes them to not have all of those compounds that we saw on the previous slide, and that can interfere with intracellular signaling and lead to an increase in apoptosis. And because cholesterol is not being produced as efficiently or as much, it interferes with the integrity of the cell membrane itself, and that can cause a destabilization in the membrane, which can lead to cell death as well. There are also some predisposing factors that a patient may have. Some ages, races, and genders are a little more preferential to being impacted by the statin-induced myopathy, but also if they have any pre-existing myopathy condition, or if they've got any kidney disease or failure in their history of diabetes, excessive alcohol use, and even untreated hypothyroidism can increase their risk of developing statin-induced myopathy. And then there's also some medications that interact with the cytochrome P450 system and therefore interact with how the statin medication is being metabolized, which can increase their risk of myopathy again. Some of these medications include antibiotics like erythromycin or clarithromycin, some antifungal medications like ketoconazole and fluconazole, also HIV protease inhibitors, and then the two big non-pharmacological ones are grapefruit juice or grapefruit, like we talked about before, but also with statins. If a patient's taking a high dose of niacin, which is vitamin B3, that may also increase their risk of the statin-induced myopathy. But we're talking about like an upper limit dose. You know, the upper limit for B3 is 35 milligrams. You're not usually even close to that in any supplement. So as long as we make sure our patients aren't taking multiple things with a lot of B3, they should be okay for this, but definitely something that we want to be aware of.
Dr. Matt.
All right. So I like to do a very quick physiology lesson here of the stomach. I'm no Dr. Bally yet, but I'm going to do my best here. So the main two cells that we look at that secrete different hormones in the body, we've got our chief cells, which secrete pepsinogen, and then we have our parietal cells, which secrete the hydrochloric acid and intrinsic factor. Now, when we talk about certain drugs that inhibit, stomach acid, we talk about our proton pump inhibitors, H2 receptor blockers. They work mainly at the parietal cell level and not allowing the stomach to produce hydrochloric acid. Hydrochloric acid, when mixed with pepsinogen, creates pepsin, which then allows us to digest our proteins properly. Not only does it allow us to digest our proteins properly, but also digest calcium, iron, and zinc, other types of cations that are really important. And we'll come back to that later because both the intrinsic factor and the pepsin are going to play a huge role in how it's important to digest all of our nutrients and the health effects it has on us if we don't do that properly. So one of the tests it's fun to do at home. I recommend to some patients is called the baking soda test. The baking soda test, all you do is you take a 1/4 teaspoon of baking soda, mix it into 4 ounces of cold water in the morning, mix it in until it's all dissolved. You drink it, and then you set a timer. And so the way that it works here is if you've ever made a paper mache volcano when you're a kid, you've got, baking soda at the bottom, you put vinegar in it, and that very huge difference between the alkaline base of the baking soda and the acidic vinegar creates a gas exchange, which the same thing works here, except you're using the baking soda and the hydrochloric acid in our stomach, which is actually even more acidic than baking soda. So it should have, even more of a reaction than the volcano. And so what would happen is we're looking for the patient to burp within a certain amount of time. They say within 3 to 5 minutes is a good range that you've got some a sufficient stomach acid. If it goes past 5 minutes, then really it shows that you're low on stomach acid. I've had patients do this and they don't burp at all. Some patients, they tell me they just feel pressure in their chest, which is still a good sign that you're feeling the gas, trying to come up. So there's, kind of some subtle signs that you've got it as well. But I've had patients tell me, they've had none at all. So that's definitely a sign that they're low on stomach acid. So getting into the different medications here, we've got our proton pump inhibitors, such as your omeprazole, which is a very common one, your H2 histamine blockers, like your famotidine, and then you've got your Tums, which are all your, grouped up antacids. And as we talked about before, not allowing the hydrochloric acid, we don't digest our proteins, calcium, iron, and zinc, which is really important. And, there's a whole laundry list of side effects here, related to the protein. We talk about the lack of muscle and later on in life of, osteoporosis being a major factor. A lot of people talk about just calcium related to osteoporosis, but protein, vitamin D, lots of other vitamins and minerals are needed for proper bone health. And then we've got the folic acid and B12. If you remember from some, physiology, intrinsic factors needed for B12, and B12 and folic acid absorb really well together. So that's how that fits into the entire picture. And, B12 and folic acid are, highly, related to different anemias. B12 and the whole cycle of homocysteine, which if elevated levels of homocysteine leads to your cardiovascular risk and different neurological disorders and, stroke and what have you. The other medications are laxatives, which help or which deplete the fat soluble vitamins. The main physiology that laxatives, the way they work is by kind of adding, absorbing more water into the colon and helping flush out all the vitamins. The way I like to kind of explain it, whether it's, right on the nose or not, is that water and fat doesn't mix well. And so not allowing the time for our body to properly absorb our fat soluble vitamins leads to a deficiency in that. And, on the list here of, vitamin A, we know, remember from like carrots, important for your eye health and also your immune function. Vitamin D, we talked about with our bone, talk about lots of different, neurological disorders, depression, anxiety. Vitamin D is needed in a lot of different situations. And vitamin E is a really important antioxidant, good for your skin, and lots of other issues as well. Vitamin K we think of with people who needing to help thin the blood, and vitamin K with the different clotting issues and also osteoporosis being a fat soluble vitamin. So we came across this study about medication-induced osteoporosis. And so talking about, what causes osteoporosis or, what nutrients are needed, we talk about having sufficient protein, vitamin D, zinc, magnesium, calcium, of course, too. Lots of people know calcium, but it's also important that, as Dr. Balliet talks, calcium is the wood to build the house being the bones, but you need your workers as well. And that's where, your essential fats, and your vitamin D and protein all comes in to play as well. So knowing the medications, as Dr. Jillian mentioned earlier, there's lots of polypharmacies going on as like abundant in the U.S. So there's lots of different people who are on multiple medications, such as your proton pump inhibitors, SSRIs, anticonvulsants, anti-anxiety, and whatnot. And so there's a wide array of people who are being depleted of lots of different nutrients that are important for not only osteoporosis, but lots of other conditions. And so then what's the solution? So we've got our breakfast blend here, and the goal here is that we want to establish or to hit on lots of different, vitamins and minerals that everyone, needs at a sufficient dose. So the goal here is that it's not too much for any one person. There's not too much of any or an excess of any one vitamin or mineral. And so the goal is that we try to hit on all the different drugs and medications that people are on. That this could be the goal to try to get as many replete as many of these vitamins and minerals as possible. And in certain cases, there's there's a couple things that aren't in breakfast blend that some people need, but not everyone needs those necessarily. So the goal is that this established hits on most of the marks, but we're going to discuss a few of the extra supplementation that you may need as well. And so let's see here. So breakfast blend has your B6, has magnesium, zinc, and vitamin D, but those are also very common nutrients that get depleted from the medications discussed earlier as well. So, vitamin B6 is really important. We call the master vitamin, and as we talked about, and hormone replacement is much needed to be repleted in lots of people. Magnesium is needed in so many different metabolic processes in the body. Lots of people are deficient in magnesium. So it's definitely one that even at the dosage that's in breakfast blend, people may most likely still need some more if they're taking certain medications. CoQ10 would be the first one that we talk about that isn't in breakfast blend, and mostly is needed, as Jillian discussed earlier, in statin medications is the most common one that's depleted. And melatonin is the other nutrient that is also needed for breakfast blend, or that's not included in breakfast blend. That's usually needed for sleep and also anxiety, insomnia. Lots of people need just the dosage usually of 1 to 3 milligrams a day added on top of what would be in breakfast blend. And then zinc and vitamin D are the last two here, which I stress to patients, like almost everyone is deficient in usually one of these two. Magnesium, zinc, and vitamin D are the core three. And usually people who are eating a well-balanced diet aren't deficient in these, but zinc is needed in over 300 different metabolic processes in our body. It's needed in all over the place. I'm getting ahead of myself because that's my next slide. But anyways, we can go to the next slide here.
So I'm going to do this, then you're back up.
I'm ahead of myself.
And you're one slide ahead. So I wanted to just talk about this because I had done this slide about hormone replacement therapy and birth control pills. And what James Lavelle and Ross Pelton showed is that the B6, which the RDA is much lower than this, can be depleted to quite a high level. And not everybody needs 25 to 50 milligrams of B6. But if you are on any kind of hormonal birth control, and so I did put all the new kinds, like when I was young, it was basically just this. People were on the pill. But now people can have a shot or an implant or a ring or a patch or an IUD that has this in there. So it's really important to discuss this with your patients because the majority of heterosexual women are on some kind of hormonal birth control, or if they're postmenopausal, they're on some estradiol. We want to be able to reassure those patients that they can have the positive benefit of being on birth control pills, or they can have the positive benefit of the estradiol, which is going to help them with their bone mineral density and protect them against cardiovascular disease. But we do not want to have the side effects. And so then they do not have to be concerned that they're on the medication because now we can tell them how much they need. So for a lot of those patients, I have on the B6 on the 25 to 50 milligram amount, I have them do it as pyridoxal 5-phosphate because I noticed that some of those women are not good at making the active form of B6, so they can take pyridoxal 5-phosphate. And then for the magnesium, to take it in the evening. So even though the breakfast blend has some magnesium, a lot of them need a lot more magnesium because of this. And we're going to know that because they're really going to have trouble falling asleep. And so 300 to 400 milligrams of magnesium, the RDA of magnesium is about 400 to 600 milligrams. So we're going to really have to bump that up when you're on any kind of hormone replacement therapy or birth control pills. We're back to you, Dr. Matt.
I think it's Dr. Jillian.
Dr. Jillian.
It's me. So this is just a more complete list of all of the drugs that can deplete CoQ10. We already talked about the cardiovascular drugs. Tricyclic antidepressants do it as well. So the amitriptyline, nortriptyline, those class of medications. Diabetic drugs can do it as well. Metformin is the most common one that diabetic patients are on, and also Fosamax in the osteoporosis class of drugs can do it. Usually a dose of 100 milligrams is sufficient enough for patients to get enough CoQ10 that they need. And again, most of these drugs, it's impacted because you're no longer able to make it yourself, so they have to supplement if they want to combat some of these side effects and make sure they're as healthy as possible.
So one of the things that we also talked about that I wanted to add was, first off, sleep is critically important. And so things like corticosteroids, non-steroidal anti-inflammatories, intriguingly, both the selective serotonin reuptake inhibitors and the benzodiazepines, which is Xanax, Valium, they deplete melatonin, as do the beta blockers and Ritalin. And so a lot of people on ADD medication, they're already so jazzed up during the day, but now they're not having the benefits of sleep. And so it's really important. Melatonin doing so many things: eye health, seasonal affective disorders, healthy immune system, and intriguingly protecting those mitochondria in the brain. Really important impacts of melatonin. You want to try to do the lowest possible dose possible. So I try to have everybody on about 1 milligram, but you could go up to 3 milligrams. The important thing about melatonin is it only helps you fall asleep. It does not help you stay asleep. So I'm going to do a presentation about sleep hygiene and the importance of either falling asleep or staying asleep. So I think I'm going to do that next week. I'll let everybody know about that. Matt, we're back to you.
Alrighty. So back to zinc, where is a very important nutrient that we need. Lots of medications deplete it, as we talked earlier with the antacids, the H2 histamine blockers, and lots of different medications that people are on. Your NSAIDs, birth control medications, ACE inhibitors, and diuretics. There's lots of different, body systems that are involved, from your brain, from muscular health, digestive, immune health, reproductive health, your skin. A very common way of physical exam finding you may see for people who have zinc deficiency is you tend to see white spots on their nails. Everyone runs and looks at their nails and like, I see white spots. So, sometimes it's just a line that's on there, but it's usually more, homogeneous across, multiple fingernails if you see a zinc deficiency on the fingernails. And the dosage being 5 milligrams per day. The upper limit, is anywhere from 30 to 50, depending on people. If you're deficient in zinc, it's not going to hurt you to go a little bit over the 5. But as you know, there's lots of different things that don't allow us to absorb zinc. Lots of different supplements you see at like Walgreens and CVS. I see usually like anywhere from 30 to 50 milligrams of zinc gluconate, which is way more than we need. But the reason they probably do that, not only is probably cheaper to put more in it to not have to measure it, but because we don't absorb it as well. So to have, to be able to absorb, usually we need just a smaller dose of a more bioavailable kind is better than, a higher dose of a less bioavailable form of zinc. And then finally, back to the vitamin D, the fat-soluble vitamin, where we talked about earlier with laxatives, depleting it, steroids, statins, different seizure and anticonvulsant meds, deplete it, as well as lots of the new popular weight loss drugs that are out there. Vitamin D is important for so many different systems as well, just like with the zinc. It's very easy to check your vitamin D levels on blood work. Usually they check for the 25 hydroxy vitamin D. On most blood works, they have the reference range being from 30 to 100. And so if you're not below 30, they don't even consider it. Usually you'll see patients that come in and they're like, oh, my blood work showed it was 25, so I'm only a little low. I'm like, well, you're more than a little low. The reference range is kind of, where the one standard deviation of the American population is. We want to be where optimal is. And, depending on the research, between 40 to 60 nanograms per milliliter. I've also seen 50 to 70. It could be, male, female, the size, body size as well is going to play a role in that. But, as long as I should say for patients to shoot for 50 is a good goal to have. If you're a little bit over that, that's great. I do see some patients go over, if they're over 100, usually just means that they're overdoing the vitamin D supplements. The most common dosage you would want would be anywhere from 1,000 to 5,000 international units. You may also see that they're in micrograms. So 1,000 international units is equivalent to 25 micrograms of vitamin D. So 25 to 125 is going to be equivalent to the 1,000 to 5,000 international units.